I'm going to start talking about imaging approach to renal masses today. Um, we'll, I'm going to give a very brief overview of the entire renal carcinoma. I won't spend much time on benign renal masses, although we'll talk about it while characterizing it. We'll concentrate on cancer because that is my day job, looking at a lot of renal carcinomas. So I've arranged this talk in a couple of broad headings. One is we'll talk about characterization of renal masses, and then we'll talk about monitoring of response to therapy. That is basically now we are moving towards metastatic renal cell carcinomas treated with chemotherapy and immunotherapy. And we'll also talk about complications of therapy. I decided after speaking to Nat, who incidentally did a fellowship with me, that this might be of interest to the broader general radiology population who may not see a lot of the complications that we see. Um, so when it comes to characterization of the renal masses, I will talk about how you characterize it, like how do you put it into different buckets of malignant versus benign lesions. And then once you have decided it is malignant, we'll just very briefly talk about staging of how do you stage the renal masses and move on. Right. So we will talk about solid masses. Now I've put an asterisk here because the asterisk means that this is only on non-fat containing masses. So if you see macroscopic fat on any renal mass, that is an angiomyolipoma. Although you might come across certain case reviews or some case reports, which are very rare, which shows fat inside a renal mass, almost always, as a rule, if you have macroscopic fat in the renal mass, it is going to be angiomyolipoma. If you look carefully, that is what it is going to be. So we are only talking about non-fat containing renal masses. And we won't talk much about cystic renal masses because that is Bosniak criteria, and we have a different kind of schema of classifications and everything. So we won't talk about cystic renal masses. So we'll talk mainly about solid renal masses. So having said that, the first question you have, once you have renal masses, the question that you need to answer, is it solid or is it cystic, right? So for example, this is an example here, of CT scans. A non-contrast or a pre-contrast CT scan and a contrast-enhanced CT scan, and you have these multiple renal lesions, particularly this one, which is a partially exophatic lesion here. The question is it enhancing? And of course, you'll do a ROI measurement, and the difference is about 13 Hounsfield units. So there is pseudo enhancement. Let's not go into pseudo enhancement. You know about pseudo enhancement, I'm sure. You can get an enhancement of up to 10 Hounsfield units, and between 10 and 20 is when you kind of start thinking, that's the gray area that could be pseudo enhancement. And when you have pseudo enhancement, what do you do next? How do you say whether this is solid or cystic lesions? So you can do ultrasound as a quick fix. And if you see a cystic lesion, you have answered the question. You can see that turned out to be a cystic lesion with some septations. So cysts are you can use all these other radiological modalities to answer the question, of course. Even in MRI, we can have the same problem. These are hemorrhagic cystic lesions, and you can see that here. And sometimes just by inspection, it is a little difficult to tell whether it is or not enhancing. What we can do elegantly in an MR is do subtraction imaging, that you subtract this image from this, and only those which enhances will be left behind. And so now you can see that this was a clean cyst. There was this is a simple cyst not simple cyst, but a cyst without any enhancing component, but just a hemorrhagic, stuff within the cyst. So subtraction is an extremely elegant way of looking at different problems in renal masses, particularly, and also in many other lesions. This is an MRI of a patient who had RF ablation. This is a T2 weighted sequence. You can see some fluid signal and also some, intermediate and low signal. And the T1 weighted sequences shows a lot of hemorrhage. And on the contrast enhanced sequence, you are no wiser of whether it is enhancing or not. But once you do subtraction, you know that there is no enhancing component. And so you know that this is a nice ablative response, and all that is just hemorrhage. So we use MRI as a problem-solving tool many times, in addition to ultrasound, particularly. Now, there are times when you have renal masses which look very similar. So one of them is cancer and one of them is not. So you can see that this is like an infiltrative renal lesion, where you have lost the definition of the cortex and the medulla, and on both of them. One of them is malignant, one of them is not. This turned out to be pyelonephritis on the left side, and on the right side, this is renal cell carcinoma. And how do you tell the difference? It is really hard, but sometimes you can get clues, such as in this patient, you have a necrotic metastatic node. You rarely see enlarged lymph nodes in pyelonephritis, but if you see enlarged and necrotic nodes in the retroperitoneum, it is likely that this can be renal cell carcinoma. Right? So you use not just the masses as such, but a lot of other ancillary kind of features to characterize these lesions. So when you look at any solid lesions, there are multiple things that you can think of. One is the size of the lesion. What about the stability or the growth pattern? And a very interesting concept called topographic localization. Where is it arising from? Is this arising from the capsule, cortex, medulla? Where is it coming from? What is the enhancement? Does it enhance or not? If it enhances, is it homogeneous or heterogeneous enhancement? What is the degree of enhancement? When you are doing an MRI, what is the T2 signal characteristic? Does it drop, signal in the in and out of phase? All these can be used to actually characterize renal masses. If it turns out to be cystic, we just follow this cystic schema. So now let's talk about size and stability. Right. Now, when you talk about size, a lot of solid enhancing masses tend to be malignant. But the smaller the lesion, the more chances it is benign. And so this was seen by a large study, where if the lesion has a diameter of less than a centimeter, 46% of them tend to be benign. And as you increase the diameter, as the lesion increases in diameter, the chances of it being benign decreases as the size increases. And that is how these renal masses actually live. Right. What about stability? So this is an example of an oncocytoma on top, and this on the bottom panel has papillary renal cell carcinoma. So obviously renal cell carcinoma. So you can see when you just by visual inspection, and these are both scans are done roughly 2 years apart, February to March. 2 years here, January and December, 2 years away. There is hardly any change in the masses. This is benign, this is malignant. And this is not very surprising, because when you look at no growth over a period of 2 years, unlike in lung lesions or whatever, no growth, 83% of them still are malignant. They may be indolent, they may be growing very slow, or they may not be showing many changes. And if it is growth, if there is growth, 89% are malignant. So it actually helps you. But that means that even 11% of those lesions which grow or show growth can be benign. And that is an important distinction in renal masses. When you look at it, just the stability does not mean benignity. It can still be malignant. So that is why renal masses which enhances are treated with a lot of respect. Um, with a lot of respect. And let's go to topographic localization. Now, we are talking about a few rarer things in this when I'm showing you, but it is useful. And this approach has helped me kind of put patients in differentials and even stop nephrectomies on a couple of individuals over the last few years. And I'll tell you how it works. So when you look at a kidney, you have the capsule, you have the cortex, you have the medulla. You try and see, and this works only if it is very obvious and a smaller lesion. You try and see where is the epicenter of this mass. So look at this mass here. This is an epicenter along the capsule. Again, this lesion is arising from the capsule or in the perinephric space. So the lesions which arise from the capsule are leiomyoma. This is a leiomyoma. This is a leiomyosarcoma. This is a very aggressive and malignant, whereas this is benign. Sometimes you even find rarer tumors such as malignant fibrous histiocytomas. right? Now that is from the capsule. The other thing that you can see is in the cortex. There are certain lesions that arise from the cortex. You have a cortical lesion here, which is a clear cell renal cell carcinoma. That is what I use here for my in my slides. CRCC is clear cell renal cell carcinoma. This is another variety of renal cell carcinoma called chromophobe renal cell carcinoma. This is an oncocytoma, which is a benign lesion. So these are all cortical lesions. The other lesions that you can see arising from the cortex are papillary renal cell carcinomas, sometimes even metastases from other lesions, particularly the breasts and melanoma metastases, which go to the kidneys, can be in the cortex. In the medulla, so when you look at the kidney, you not only have the cortex, but there is a medulla here, and that is very obvious in the corticomedullary phase of imaging. So the lesions that arise from the or from the medulla tend to be collecting duct RCCs or medullary renal cell carcinoma, large transitional renal cell carcinoma like this, which is infiltrating into the medulla, sometimes metastases, hemangiomas, kind of rare, but you can see all these things look different to the lesions that you already have seen here, which arise from the cortex, right? So these are more infiltrative. They maintain the shape of the kidney. They are not ball-like lesions, which is what these are. They are more infiltrative. These are medullary lesions. They're not only transitional cell carcinomas, collecting duct and medullary carcinomas. There are certain rarer tumors which arise or which appear to arise from the renal sinus fat. Now, one of the more common ones is the transitional cell carcinoma of the renal pelvis, which can break through and then go into the renal sinus fat. Sometimes, very rarely, you can see hemangiomas, and the clue for that is going to be phleboliths. You can see some calcifications, and a rarer form of tumor, which is a mesenchymal tumor, which is solitary fibrous tumor or hemangiopericytomas. These are the ones that come from the sinus. So just by going on topographic localizations, you can actually start putting the diagnosis in different buckets. Rather than saying enhancing renal mass, I still say enhancing renal mass, probably renal cell carcinoma, maybe this or that. And when you're having a conversation with your clinicians, that you can do that. The other thing that you can use is the enhancement. There are two things that you can look for in the enhancement: the pattern of enhancement and the degree or the degree of enhancement. So the pattern of enhancement tends to be homogeneous or heterogeneous. Now, even in heterogeneous, there are multiple different types of heterogeneous enhancement. Lesions which are homogeneous enhancement tend to be benign or indolent. There can be some cancers which are homogeneous, but they are usually indolent. For the example is a type 1 papillary renal cell carcinoma or a chromophobe renal cell carcinoma. They are not very aggressive like clear cell renal cell carcinoma. So they have homogeneous. Now, these are all just guidelines. I'm not saying that this is always true. These are all clues that you can use to kind of put renal masses into different buckets. Then there is heterogeneous enhancement. There is a good paper a few years ago in radiology which kind of characterized enhancement into different types, heterogeneous and mixed, that is necrotic and stuff like that, heterogeneous and solid, heterogeneous and peripheral in the sense it is a predominantly cystic lesion with just a few enhancing areas in the periphery and stuff like that. So, and then they looked at the odds ratio for aggressive malignancy and found that, the heterogeneous and mixed is a lot more aggressive because of necrosis. That is what it is, versus heterogeneous and solid and heterogeneous and peripheral. This is predominantly cystic. So you can see that the type of enhancement actually also informs, and this is very useful in the current day and age where there is a paradigm of observing renal masses rather than doing renal resection. And so that is something that you can use, right? And this is an area of interest evolving. We have a lot of patients we just observe, for stability, and we know that they have renal cell carcinomas, but we are not going to offer them surgery or any other intervention, but just observe them. And this kind of pattern will help us, categorize them into likely indolent and aggressive and stuff like that. Now, degree of and so I'm going to show you some examples of heterogeneous enhancement. So this is an example of a clear cell renal cell carcinoma. You can see how enhancing it is. It's heterogeneous. This is usually an aggressive malignancy. Usually nobody wants to sit on this. Whereas this is an oncocytoma. We discussed it. This is one of the benign lesions. And you can see it is usually homogeneous. Not always a rule, but generally when you take a lot of cases, you'll see that most of them are homogeneous. Likewise, if I look at lipid poor angiomyolipoma, you can see that it is generally homogeneous. Right? These are rare, but generally homogeneous compared to a renal cell carcinoma, which is very heterogeneous in its enhancement. This is a chromophobe renal cell carcinoma, generally more indolent, and you can see how it is homogeneous compared to the clear cell renal cell carcinoma, which is aggressive. So these are all just take-home points for all of you practicing, just to understand that there are different things. Now, there is also different types of enhancement in the sense of what is the degree of enhancement. Now, you look at it, this is a pre-contrast study, this is a corticomedullary, and this is an excretory. It's the same panel I'm using. So in the corticomedullary phase, you can see that the clear the cortex enhances a lot. The clear cell renal cell carcinoma, the maximum sites of enhancement enhances almost to the same degree as the cortex or more. Whereas on the other hand, we have the second most common type of renal cell carcinoma, that is papillary. You see how it does not enhance to the same degree as that of the cortex. And there is a little bit of a washout in clear cell renal cell carcinoma, and in the papillary, there is not as much of a washout. And so this pattern has been studied a lot, and there is a lot of publications on these things. And we sometimes use, and there is even now a group in UT Southwestern in Dallas, which actually give a clear cell score, clear cell carcinoma score. And these are all kind of small steps that we take to identify those cancers which need which need surgical treatment versus just observation, right? So this is an example. If I were to draw the graph of enhancement on a clear cell renal cell carcinoma, so on the free, of course, there is no contrast. Once you give contrast, it enhances a lot, and then there is washout in the excretory phase. In the papillary, on the other hand, it doesn't enhance as much. You can see that. Doesn't wash out too much either. The chromophobe is somewhere in between, right? The angiomyolipoma is very similar to clear cell renal cell carcinoma, and oncocytoma overlaps that of clear cell renal cell carcinoma. So you can clearly usually say what is papillary, but then there is this overlap of a lot of different subtypes. So what can you do about this? Now these are all investigational questions. Now, for example, you can do an MRI. You can do an MRI. The MRI gives you a lot of different things, like there is a T2 weighted signal intensity, there is an ADC value, there is an in and out of phase. For example, this is a patient with clear cell renal cell carcinoma. The T2 signal is increased. It's usually increased. It's higher. When I say higher, it is that of the rest of the renal parenchyma. You can see that there is higher signal compared to the rest of the renal cell carcinoma. In some cases, it can be decreased or it can be iso intense, but most of them are hyper intense to that of the renal cortex. Now, when you do in and out of phase, usually there is no drop in signal, but occasionally you can get a drop in signal like this. You can see that there, right? So that is a drop in signal. So clear, but then when you give the contrast to this, it enhances the same way as the previous slide. That is, it enhances very avidly towards the same extent as that of the cancer. So if I have a T2 signal, high signal intensity lesion, which enhances a lot, and then I know that this is clear cell renal cell carcinoma. Now, this is a papillary renal cell carcinoma. Generally, the T2 signal, the lesion is low signal, lower than that of the than that of the renal cortex, as you can see. Doesn't enhance too much. Sometimes on the lipid poor AML, I should have put in a T2 weighted sequence. I don't know, it removed. But anyway, lipid poor AML drops its signal as well in out of phase. But on T2, it is usually dark. It is very dark on T2. And so that is how you differentiate it. And also you have ADC values. The benign lesions are not very restrictive versus that of the renal cell carcinomas. And we generally don't measure the ADC value and report it as such. So now we have come to renal mass characterization, and I'm sorry, it's a very fast overview. You can read more about it, or you can email me. Um, I'll share my email later. If you have any particular questions, let's go a little bit towards the staging. Now, staging is more of an academic, um, an academic question. Unlike let's say rectal carcinoma, where staging makes a huge difference, whether it is T2 or T3, it makes a huge difference. In renal cell carcinoma, it may or may not be very important. But there are certain areas where you have to be especially careful while staging. Now let's go to that. The first two, the T1 and T2, are just limited to the kidney. That means it is within the renal parenchyma. It has not broken through the capsule of the kidney into the perinephric space, neither has it gone into the renal sinus fat or the renal calyx, or it has not gone into the renal veins. Once it does that, it goes into the T3 category. In T3, there is a way of differentiating the ones which just go into the fat, that is either the renal sinus fat or the renal perinephric fat, that is T3A. You're talking about T3B, that increases the risk because now it has gone into the renal vein. If it goes into the vena cava, if it is T3A also extends into the renal vein, into the segmental renal vein or muscle containing renal veins. T3B is where the tumor thrombus is within the vena cava. Now it has gone from the renal vein into the vena cava. So that increases the odds or makes the surgery a little bit more challenging. If it is below the diaphragm, it is T3B. If it is above the diaphragm or invades the wall of the vena cava, which is again a difficult radiological question. But anyway, if it is above the diaphragm, it is called T3C. Why is it important? It is because when it is a T3C tumor, a renal surgeon alone may not be able to do this surgery. Usually, at least in our centers, they involve the cardiothoracic or vascular surgeons to come in and then help them resect and reconstruct the inferior vena cava. All right. T4 is once the tumor goes into the adjoining structures, either the muscle, sometimes you can see it going to the psoas, or just goes beyond the Geroda's fascia, or just infiltrates into the ipsilateral adrenal gland, or sometimes into the liver. So this is the TNM staging, and of course, the more aggressive tumors are going to be T2 plus, right? Now, when it comes to T3, there are some T3s which are more important than the others. If the tumor is just going into the perinephric fat, it may not be that important. Of course, there is a prognostic indicator, but it may not be that important because the surgeon will remove it anyway, right, along with the fat. If it goes into the renal sinus fat, he will remove it anyway, he or she will remove it anyway, but the surgical complications or the surgical planning might be a little large, it might take a little longer. Or if it is in the renal sinus fat, our interventional radiologist colleagues, if they have to do an ablation, may have to be even more careful, right? So those are all the kind of things that we talk about. Now, this is what we were talking about. Perinephric stranding is common. Perinephric stranding is not equivalent to involvement of renal perinephric fat. You need to understand that perinephric fat has a lot of spaces, and it can be affected by edema and third space fluid and stuff like that. So rather than stranding, if you see nodularity like this, it is more likely that the perinephric fat is invaded. Just the stranding is not very informative. And you can see an example of this tumor in the coronal reconstruction, and there is this tumor which is actually abutting the renal sinus fat, maybe even effacing it. You can see that the sharpness of the renal sinus fat there is a little lost. So the question is it invading the renal sinus fat? Now that's an important question sometimes, particularly for the surgeon. So we try to look at this um, in a methodical manner. So what we did was in our center, this is one of the research projects that I was involved in. Uh, what we did was we divided the tumor and its relationship with the renal sinus fat as not involved. That means clearly there is a normal renal tissue between the renal sinus fat and the tumor. There is one which abuts. The tumor just goes close to the renal sinus fat, but it really does not go into the renal sinus fat or distort it. There is a tumor which actually distorts the renal sinus fat. It abuts and distorts, and another which actually clearly invades into it. Right. So what we did was we looked at a lot of patients who had radical nephrectomy and then scored our lesions like this: not involved, abuts and distarts, and direct invasion. And what we find, it was very interesting. Then these were all patients with clear cell renal cell carcinoma, not anything else. So this was very, and then when we kind of compared it to the pathology, when we said it is not involved, none of them were involved. And that is obvious, not surprising. What we were wondering was what happens if it abuts? How many of them actually involve the renal sinus fat? Not a lot. If it abuts, 86% of them were not actually involving the renal sinus fat. That was very interesting for us. But more surprising was if it abuts and distorts. We thought that most of them should be involving the renal sinus fat because it is distorting. But actually, we were surprised that 75% of them were actually not involving the renal sinus fat. That means only 25% of them had renal sinus fat involvement when the CT scan on we scored it, you know, using coronal and sagittal and that is what we found. When we found direct invasion, of course, most of them were actually invading. And this is for the renal sinus fat. The same thing we did with renal calyx. What did we find? It is even lesser. Even when the tumor distorts the renal calyx, 96% of them were actually not involved. That's very interesting because, of course, there is a muscular wall of the calyx which is actually protecting it, which is very useful. The other thing is if if we thought that the calyx was invading or invaded on the excretory phase, most of the time we were wrong. The pathology did not show it. So clearly, what we learned from this is in clear cell renal cell carcinoma, we overstage if we are just looking at these things. So the surgeons were not, they were saying when we went and presented it to the surgeons, they said, we are not really surprised, but this is very useful information because we always find you guys say it probably involves the renal sinus fat or calyx, but most of the time we don't find it. And that is basically what this study showed. Right. Is an example of tumor thrombus in the IVC, as you can see, and neovascularization is how you call it, tumor thrombus versus blind thrombus. Adrenal involvement is upstages the tumor to T4, and you can see it is on CT or even MR. It is easy to exclude. If you see a nice fat plane or fat separating the tumor from the adrenal gland, you can say adrenals is not involved. But if the tumor is big enough and it abuts the adrenal gland, like in this case here, that you can't see the adrenal gland separate from the upper pole tumor, you can't really tell whether the adrenal gland is involved or not. And I guess, I've not looked into this, I guess a lot of the tumors which actually on CT or MR looks like being invaded probably is just being effaced. We don't know. But at least for now, we can say CT or MR has a high negative predictive value, but a low positive predictive value. So when the adrenal gland, we are not very sure, usually comes out along with the nephrectomy specimens. Liver is another common on the right side of renal tumors. It almost looks like it is being involved. Sometimes it is just being distorted, and it is not really involved. You need to be a little careful. Sometimes what we do is we look at the vessels and see if the vessel that is separating any part of the tumor is a branch of the hepatic artery or any of the vessels supplying the liver, and that is more useful for us to tell whether the liver is involved or not. And in this case, we could trace some of these vessels back to the vessels in the in the hepatic vessels, and so we could tell that this was clearly involving the liver. But we do find very large tumors displacing the liver but then when they go into resect it, they find that the liver is not involved. So far we have talked about characterization of renal masses and staging. How are we doing for time? And now we will go very quickly and give an overview of monitoring response to therapy. Um, Nat or one of the panelists, is there any questions for me so far on this? Or we can do the questions a little later.
I do not. I do not.
Okay. So we'll go to the next part, which is monitoring response to therapy, which I think is very important and very unique in renal cell carcinoma. The reason is we use a lot of different types of chemotherapy. Now, the treatment generally depends on the stage. This may be changing now with some of the immunotherapy and also genomics, but I think by far in most places it's still true. If it is stage 1, 2, and 3, that means there is no metastatic, non-metastatic renal cell carcinoma. It's usually nephrectomy. The investigational question is, do we give adjuvant therapy? That means do we give chemotherapy prior to surgery and then do surgery? That is an investigational question. When it is stage 4, that is where things become interesting. Renal cell carcinoma still sometimes, even if it is metastatic, gets cytoreductive nephrectomy, particularly if their performance status is very good. If they are quite healthy and independent, they might still go for resection of the primary. Now, there are some trials in our institution, and I'm sure in many places, where if it is, they might be trying immunotherapy now based on the genomic or foundation one analysis. But this is basically how the general overview. Once it is metastatic, it is still a surgical disease. Metastatic renal cell carcinoma is still a surgical disease, but systemic therapy is added, of course. So when we talk about systemic therapy, there are 3 different groups. One is the general chemotherapy or cytotoxic chemotherapy or hormone therapy, where they use fluorinated pyrimidines, capecitabine or gemcitabine or things like that. There are also molecular targeted therapy, which is generally the VEGF therapy, the anti-angiogenic, the TKIs, the mTOR inhibitors, and immunotherapy, which is being used. In fact, renal cell carcinoma, we have always used immunotherapy because many of them were being treated with interleukin-2 many years ago. But when we talk about immunotherapy, we don't talk about interleukin now, do we? We talk about all the checkpoint inhibitors, like nivolumab or the others, or pembro or stuff like that. And that is now emerging within renal cell carcinoma. The general traditional cytotoxic chemotherapy generally doesn't do very well in renal cell carcinoma. There are very poor response rates. And so it is only reserved for some non-clear cell renal cell carcinomas, such as sarcomatoid, collecting duct, renal medullary carcinomas, etc. What is used generally as the first line of treatment in clear cell renal cell carcinoma and the others are the molecular or targeted therapy, that attacks the VEGF pathways. They are usually small molecule tyrosine kinase inhibitors like sunitinib, pazopanib, axitinib, and all these things. They have very similar ways of action, or they act at the receptors of the VEGF, or you can have a monoclonal antibody, or that is bevacizumab or Avastin, which acts on the VEGF molecule itself, or down the line along the pathway in the mTOR pathway where the temsirolimus or everolimus can act. So they all have very similar effect by starving the carcinoma of growth factors that is needed for angiogenesis. And so this is what is more commonly used in renal cell carcinomas. Of course, there is immunotherapy. We talked about interleukin, which just recruits a lot of immune response and triggers it. And then now there is a lot of these checkpoint inhibitors or PD-1 and PD-L1 inhibitors that are used. There are several immunotherapies, and let's not even go. These are all novel immunotherapies being studied, not just the checkpoint inhibitors. There are 3 classes. There is a CTLA4 inhibitor, PD1, PDL1. There are vaccines. There are, T cell agonists, which is cytokines and stuff like that, and CAR-T. These are all investigational. But for now, we can say that the nivolumab is being used very increasingly in a lot of our patients in renal cell carcinoma. So when you give this chemotherapy, what happens to the assessment? So for that, generally we talk about WHO, RECIST, immune RECIST, CHOI criteria. I won't talk too much about this because I think in the interest of time, so that we'll have some thing for questions. We all know about WHO criteria, RECIST criteria, which is all basically an anatomical or a size-based criteria. Now, these have their own problems. Why? Because when we looked at the the chemotherapy, we talked about VEGF inhibitors, which actually is an anti-angiogenic factor. So it decreases the enhancement and stuff like that. So those kind of findings are not incorporated in the RECIST criteria, or nobody uses WHO anymore. But anyway, the RECIST criteria. And so some people started questioning, is it good to use it? Because like, for example, in the next example I'll show you, this is a renal cell carcinoma, which was treated with pazopanib, and you can see the size doesn't change, but the tumor has decreased in its enhancing characteristic. And so obviously there's a lot less solid tumor, but the size is the same. On RECIST, you'll say you should actually categorize this as stable disease. So there have been newer criteria, um, like I wouldn't say new, but it's been allowed, which also includes the enhancement or the attenuation characteristics, or the ROI. And the most popular one, or one of the first ones, is called the CHOI criteria, where not only are you looking at the size, but you're also looking at the attenuation. Now, based on CHOI criteria, there are several other criteria like modified CHOI, mass criteria, and several other criteria, but they all come to the same principle, that not only the size, but also the appearance of the metastasis is important. I'm not going to go again in interest of time into the more details of this. So just like RECIST, you have complete response, partial response, stable disease, and progressive disease. And you can actually look this up, the CHOI criteria. And what has been shown is the RECIST CHOI criteria is able to predict the responders versus non-responders better than RECIST. And this is a RECIST criteria. You can see the dark line is responders, and the dotted line is non-responders. Very similar flow, but then once you use CHOI criteria, there is more of a difference between the two graphs. So you would be able to predict who is responding and who is not responding if you use these kind of functional criteria more than just the anatomic criteria, right? Not only that, we have multiple. So there is, as I said, people modified it a little, rather than or, they would put an and call it modified CHOI criteria. And there is also a mass criteria, which is morphology, attenuation, size, and structure based on, I think this came from Cleveland Clinic, where they use a little bit more descriptors, right? So central fill-in versus new enhancement and stuff like that. But the principle is exactly the same, that size is not able to answer your question. It has to be size and morphology, right? I won't go into the texture. It's not shown a lot of reproducibility, but we'll go very quickly to immunotherapy that has been used quite a lot. One of the features of immunotherapy is you can either have a response, which is very good, or you can have progression, or you can have what is called pseudo progression because of a lot of lymphocytes that come into the tumor or metastases, and the tumor or the lesion actually looks increasing. And so this is not very common. When immunotherapy was started, we all got excited. A lot of these progression, we called it as maybe pseudo progression, but we are seeing it in less than 10% of our patients that actually have pseudo progression. Most of the progression is true progression. So what happens here? So I'm going to give a few examples of pseudo progression here. So this is an example of all the different types of response with immunotherapy. So either you have very good response, or a stable, kind of response, or sometimes it increases in size and then later decreases. Um, and so that is called pseudo progression. And so this is an example of a patient with melanoma, and it is seen because melanoma was the first cancer we started using in immunotherapy, and so we see a lot of this. So this is the baseline after week 12. You can see that it actually looks really bad, but then after a while, in week 24, everything is gone. So this is just the profuse immune response that is happening because of immunotherapy, and the same thing can be expected anywhere else. So liver metastases looking larger, later resolving. Same with this renal mass, increasing in size, later increasing even more, and then later resolving, right? uh, Pulmonary metastases showing very similar. So this kind of pseudo progression makes you modify the response criteria that you don't use for when you see disease progression. You just want that to be confirmed by in two consecutive observations, at least 4 weeks apart. So when you see a new lesion in immunotherapy, or if a lesion increases in size, you want a confirmation at the end of at 4 weeks before declaring that this patient has progressed. Um, I'm going to very quickly go. I'm just going to skim over the contrast enhanced ultrasound scan and dynamic ultra CT MR just to show that these can show response much quicker. So this is a CT perfusion day one pre-treatment. Once you give treatment, you can see that there is not much. This is day two. So you can see that the tumor or the chemo is working very fast. So rather than waiting for 4 weeks, 6 weeks, 8 weeks, you'll know whether the treatment is working or not immediately, right? This is a similar kind of example of a hepatic metastases um, with contrast enhanced ultrasound scan done at very short intervals and showing that there is not much of enhancement that is happening on the post-treatment trial. So you can actually predict response much quicker. I'm going to skim through, I'm going to skip this slide. So in summary, although RESIS 1.1 is the most widely used, even today, um, the uh, the it can underestimate response. When you are actually reading, when we read, we look at the morphologic um, appearance of the tumor as well before actually declaring whether the tumor is responding or the metastasis is responding or not. Be a little bit aware of the pseudo progression in immune therapy, right? And functional techniques, which is what I showed, the perfusion and stuff like that. They are all investigational still and need widespread acceptance. One of the problems with that is it's very time consuming, and also if you're using CT, a lot of radiation. So we have shied away from using that in our institution. Um, Complications of therapy, I think, is one of the most important that we come across and less talked about. Um, I'm going to spend a little bit more time on this, and I'm willing to stay back to take questions later, because I think one of the most important, one of the most common um, presentations to our ER, that is emergency room, is actually complications of therapy. We don't take any trauma or anything. We just take patients with who are our patients to our ER. So most of our patients come with complications of therapy. Uh, what are the common complications of therapy, particularly when you look at molecular targeted therapy? Um, that is, the VEGF inhibitors or the EGFR inhibitors or everything. Most common is going to be pneumatosis coli or bowel perforation. You can see that, right? If you look at immune therapy, most common is colitis. Right? So the one of the more worrisome for me is bowel perforation. And bowel complications are very common and can be associated with significant mortality. Um, this this is a very common scan in our practice. Patient with renal cell carcinoma treated with pazopanib. I don't even have to know the history. When I see jejunal mucosal foldings thickened like this, I know that this patient is on pazopanib. I sometimes surprise my residents and fellows by just looking at it saying, this patient is on pazopanib, isn't he? And they'll say, how do you know that? This is a signature, right? And this is very common. Um, this is an example of a patient on sorafenib You can see, sometimes they can have colitis or enteritis. The colitis here or the enteritis is not because of infection. Most of the time, think about what is sorafenib doing. It is actually uh, it is an anti-angiogenic. So these are most likely ischemic. So you need to be very careful, and you need to look for ischemic colitis. It may not be infectious colitis or infectious enteritis. Um, so when you think of complications of VEGF or VEGFR chemotherapy, think of anything that actually um, can be affected by the anti-angiogenic action. Uh, for example, there can be ischemia or impaired wound healing. That's why after surgery, usually most of the oncologists wait at least 6 to 8 weeks or even sometimes longer before they add any of these, particularly Avastin. They don't want wound dehiscence or bowel perforation or any of those sutures not heal. So that is the reason why. They can also cause endothelial damage and hemorrhage and thrombosis, enteritis that we talked about, and other important ones which we can't predict, like reversible posterior leukoencephalopathy. I don't see any of this, thankfully, because I don't know what a brain looks like. I have not seen a brain CT scan or MR for a long time. I just do body. But I'm sure you guys know a lot more about this. Pancreatitis, we see that sometimes. Acalculous cholecystitis is common. Cardiac impairment um, is another one. Cardiomyopathies that you see. Perforation. These are some collections from my in the last few years. So you can see that there is alteration of the GI microvasculature from VEGF therapy, and you can have this is a bowel perforation example. This is a patient with pneumatosis coli, right? It is very common in patients who receive bevacizumab or Avastin. It's almost 11%. In one clinical trial, 11% of patients had GI perforation. It is slightly decreased. It's about 1.3% based on a very large meta-analysis in patients who receive TKIs or tyrosine kinase inhibitors. Um, Again, the same mechanism of action. You can even expect fistulization, enteroenteric fistula, enterocolic fistulas, and stuff like that. Um, Hemorrhage is um, uh, it's not very common, but it's more devastating. This was one when I was on call, and this patient had multiple hepatic metastases, was given Avastin, and patient presented with a lot of abdominal pain, and there was a lot of hemorrhage, a very hepatic hemorrhage, right? And serious hemorrhagic events are quite common. So usually you want to be careful in patients who have brain metastases that can bleed and cause more problems. Thrombotic events are also common. Sometimes you need to be very careful looking at thrombus um, uh, within the superior mesenteric veins or stuff like that, which can create ischemic presentations. Not only in the bowel, but also that can be seen in cardiac or cerebrovascular as well. So anywhere in the body. Um, Pancreatitis, an example of pancreatitis. It's pretty common. When I say common, these are seen in less than 1% of our patients who receive it, but I'm saying about amongst the complications, you can expect these things. So the patients who present to our ER on chemotherapy with abdominal pain, we are looking mainly for bowel complications. We are looking for hemorrhage. We are looking for pancreatitis and stuff like that. Acalculous cholecystitis as well. Patients with mTOR inhibitors usually get pneumonitis, and this is pretty common. This is another patient who is renal cell carcinoma, and I see these lungs. I know that this patient is on everolimus or temsirolimus, usually everolimus. 36% of the patients develop pulmonary abnormalities in one CDs. Um, Immunotherapy provides a more interesting kind of plethora of complications. The reason is you are actually triggering nothing but autoimmune reaction inside the body. The incidence is pretty high. It's almost like 72% have some adverse event, 22, 25% of patients have high-grade adverse events. The most common sites are GI tracts for us. I mean, I'm talking about imaging, endocrine, that is usually pituitary, liver, skin. We don't see it, but the clinicians see a lot of skin reactions to immunotherapy. Um, when the most fatal of all these things is the GI. Death rate, it's usually related to perforation. It's rare, it's less than 1%, but when that happens, it's usually related to a GI complication. So you need to be a little careful with those things. So think of immunotherapy as an autoimmune. So it enhances T cell activation and proliferation, and you can have reactions involving any organ system. We see any and everything. Um, Enterocolitis, hepatitis, which you may or may not see on imaging, neuropathy, hypophysitis, we can see that on MR, pneumonitis that we see on CT, benign lymph node enlargement, most common call of metastatic or progression disease. We see that in PET CT all the time. Patient gets immunotherapy, all lymph nodes light up, and we don't know what is happening. And sometimes somebody might call it progression, but it's not. It's pseudo, or it's just a reaction to the immunotherapy. Myositis, that is lesions in the muscles, fasciitis, and retroperitoneal fat infiltration and stuff like that. And I'll show you some examples of that. For example, this is an example of a patient with autoimmune colitis. The colon is a little thickened. Not a great image, but you can see here it's a little, there is a lot of circumferential thickening of the colon. If there is bleeding, there is grades of colitis. You can have grade 1 to grade 4. Grade 4 is the one which can be life-threatening. That means you're looking at perforation, you're looking at hematochezia and stuff like that. So you need to be, little, you need to dig a little into the patient's history chart or speak to the clinician to find out. This is very common, autoimmune hypophysitis, almost seen in about 5 to 10% of the patients, or seen in 13% in trials. Patients can present with hormonal deficiencies. The pituitary enhances quite a lot. Or you can see pneumonitis. This is a very nice example. Large mass, treated with immunotherapy, very good response, but then you can start seeing all these ground glass opacities. This is pneumonitis, and this is immune-related pneumonitis. Sometimes you can even see panicolitis in the mesentery, just fat enhancing. It almost looks like fat necrosis or some degree of fat necrosis that you can see. An example here of, of fasciitis, all the anterior abdominal fascia. You can see how on the PET it looks really impressive. On CT, it's a little more subtle, but this patient presented with abdominal pain. Not only that does this patient have fasciitis, but also has sacroiliitis. This is all related to immunotherapy. So you either withdraw immunotherapy or add corticosteroids, and these symptoms resolve. Sometimes you get myositis. This is a patient who developed these lesions here. Now, if it was renal cell, this is not renal cell carcinoma. If it was renal cell carcinoma, you might start thinking, oh, those are metastases. It could be, but these are myositis. Treated. We usually biopsy this. It turns out to be, if it turns out to be inflammation, then just they are treated appropriately, and everything just resolves. So I think I'm coming close to the end of the hour, and in summary, we have covered a lot today. We talked about characterization of renal masses. We talked about all non-containing renal masses. We excluded cystic. We talked about size, enhancement, topographic localization, the degrees of enhancement, and some MR characteristics. We talked about multiple different groups of chemotherapy that is used, and very, very briefly about the response criteria, particularly of just the limitations of size-based criteria, and some complications. So with that, I thank you very much for listening, and open myself for any questions you might have.
Thank you, Professor Vikram. That was quite a very elaborative talk on renal mass, and that was quite precise and illustrative. Let's start our question and answer session. I have a question from our audience. There's a query about do not touch lesion criteria. Is there any do not touch lesion criteria for non-fat enhancing solid mass? Would you like to highlight on that?
Well, the concept of do not touch lesions goes back to the time when we were worried about seeding um, of a renal cancer along the track, the biopsy track. There has been a lot of experience, uh, with biopsy and also after renal ablation, that concern was um, was overstated. That means it is considered to be quite safe to biopsy most renal masses. And so the only mass I have seen where I actually am a little nervous about sending for a biopsy, where I see seeding, is if I'm convinced that the patient has transitional cell carcinoma, right? So if I see a lesion which is infiltrated, which I think is actually a renal mass coming from the renal pelvis infiltrating, and the clinician wants to biopsy it, I might just call them and say, hey, this may be a TCC, because I've seen, in my experience, this is anecdotal, seeding along the TCC. Does that make sense? Everything else, you are okay to biopsy.
Sure. I think that answers the question. Any questions from the Josh or the Nat?
So there is a question from one of the attendees. When do we expect complication of therapy to occur? Is it more often during initial therapy? So that's a great question. When it comes to we don't have a good understanding of when the complications can occur. Usually it is an additive effect. Most of the time, it may occur after a few cycles. We don't think that there is a good time for the complications to occur. There is not a good thing. When it comes to pseudo progression, I'm not considering this a complication. Pseudo progression in immunotherapy, that might be usually about 12 to 16 weeks after the initiation of immunotherapy. That's not a complication, but that's more of a pitfall. But when it comes to complications of immunotherapy or complications of all the targeted therapy, I'm not sure there is actually a timeline, or if there is, I'm not aware of it. I'm sorry.
Okay, here's a quick question from one of our audience. How to differentiate a hemorrhagic cyst from papillary RCC? Both look hyperintense on pre-contrast image.
Yeah, so that's a great question. On CT, it is a little difficult, as you can see in this. This can be a papillary renal cell carcinoma. In fact, papillary renal cell carcinoma, there are two types. One is called type 1, and the other one is type 2. Type 1 is a little more indolent. Type 2 is a little bit more aggressive. Type 1 is a lesion which actually grows and necros, grows and necros, grows and necros. So it can actually arrive to you like a hemorrhagic cyst. That's a great question. So the way we look at it is, we are looking for any kind of enhancing lesion along the wall. Either that or on ultrasound to see if there is any nodularity within the wall. And if you see that, then it may be papillary renal cell carcinoma. Or we use MRI and use the subtraction.
I do have a few questions too. Is there any role of PET-CT in renal cell carcinoma?
Uh, so the problem with PET-CT, let me go to a slide which I pushed. The problem with PET-CT is it's not very well studied. The reason is there is so much renal activity there. Um, that is where, gosh, where is it? Where was my PET-CT? There was a slide, I'm sorry. Anyway, if I find it. Yeah, so this is a slide which I kind of very fast skimmed through. There are several small studies. The problem is not all RCCs accumulate contrast, and the sensitivity and positive predictive value is not very. The sensitivity was 75%, which is not that great. And positive predictive value is usually good, but there is a high false negative rate, and so that is why we don't use it regularly in but we do use PET-CT for metastatic setting. If there is a lot of metastases, and sometimes we want to get that sometimes. That's not very well studied systematically like other cancers. Like, for example, we know the answer in colorectal malignancy, or even to a certain extent in pancreatic. Not a lot of things have been done in renal cell carcinoma. There are certain new tracers that are studied, like the one I came across was girentuximab. We don't do this, but this is out there. I think in Stanford they do this in some trials. It's a monoclonal antibody which can actually tell you whether enhancing lesion is renal cell carcinoma or not. It is more specific. This is an example of a girentuximab PET-CT which lights up. This was a renal cell carcinoma. Whereas there is an enhancing mass here, it doesn't light up. This is not a renal cell carcinoma. This turned out to be a oncocytoma. These are all not FDA approved, so we don't get paid. If we don't get paid, we don't do it. That's how it is.
In terms of the treatment, since it seems like you mentioned a lot about immunotherapy, is there any prognosis better? The patient's survival rate, mortality rate has decreased after this immunotherapy era, or is still the same?
That's a great question. We're still learning about it. Now, what happens in most cancers is uh, is they get what is called a genomic profiling done. And in the genomic profiling, they do study a few things. One of them is called the tumor mutation load. There are certain other markers they look at, which actually predict whether a patient will respond, or what are the chances the patient can respond to immunotherapy or different types of therapy. And that is generally what is being done almost in all different or big cancer centers, including ours. Um, in So when you actually apply immunotherapy on that basis, that means you select the patients based on the foundation report. The prognosis, when you say prognosis, their survival improves slightly, and that was the reason why nivolumab was actually given. So if you look at this, nivolumab versus everolimus in advanced renal cell carcinoma, this is from 2015. There must be a lot more data on this now. This showed improvement in progression-free survival and overall survival in metastatic renal cell carcinoma. And so that is why it was given.
In terms of treatment, this surprised me a little bit. Seems like the early stage of renal cell carcinoma, we do very aggressive, like nephrectomy, but the advanced stage, like T4, that go like into tumor reduction and then followed by something else. What about like a small one, like suppose T1? Do you do like RF ablation or something like that?
Yeah. So a small renal tumor, you can put them into two buckets. One is wait and watch. You have a long conversation with the patient, and then say, we can watch this. We can watch this. Particularly if the patient is older and doesn't have very good physiologic reserves or stuff like that. Um, you can do that, or you can do an intervention. Now the intervention depends on the surgeon, and the surgeon and the team that you have. So we do offer ablation to a certain number of patients. That is based on the conversation. So ablation, um, partial nephrectomy. These are all the things that the patients undergo. One of the problems with ablation is they need to get multiple repeat examinations, like CT scans, right? And so a lot of patients may prefer to go for minimally invasive partial nephrectomy from the surgeons because they don't have to worry too much about residual or recurrent disease and stuff like that. And so ablations are usually done on a select individual. Either it is the patient's preference or the patient's conditions that dictate it.
Thank you.
Hi, Dr. Raghu. This is JP again. Thank you so much for wonderful talk. Very educative. Thanks a lot. I had one question, but not regarding the solid renal masses. This is just, I need your opinion on the proposed modified Bosniak 2019 classification. So we always used to use the Bosniak, the old Bosniak, which was initially done for ultrasound, but this one is for more like cross section with CT and MR. So what are your thoughts about that?
So I think it is a move in the right direction.
Uh-huh.
It is a great paper if you can read it, and I
Yeah.
recommend everybody to read that. One of the things that was a little bit, Bosniak is one of the best ways. In fact, it actually inspired a lot of radiologists to do body imaging because there was something that you can actually give a score and do something about. One of the first things in body imaging that was used was Bosniak category. You can categorize as 1, 2, and then say this is benign, 3, or 2F and 4, and it was wonderful. But what was lacking in that Bosniak category, giving a lot of respect to Martin Bosniak, is there was a lack of definition of what is a cystic lesion in the first place, and so people will say, I know what a cystic lesion looks like, but there might be someone who is a general radiologist or somebody who doesn't do body radiology that often, who may not know exactly, or may consider a largely necrotic lesion as a predominantly cystic lesion. So those kind of definitions were included in the more modified. So the definitions were kind of cleaned up. The other thing is the number of septations for which, when you would call this too many septations or too few septations, the number of septations were more defined in the modified. It's not modified, but more clarified, I would say,
Yeah.
clarified
Yeah.
Bosniak definition. So now you know how many septations should be there for me to call it multiple septations. What is the thickness of the septations that needs to be? So all those things were kind of defined a little bit more, right?
Okay.
So that now you can use this as a research tool and then find out more about these cystic renal lesions. So that is the idea of the newer avatar of
Okay.
Bosniak.
So is that the reason again we don't have like how we have LIRATs and PIRATs for everything? We don't have anything like a rat system for renal cell carcinoma, right? Do we?
So yeah, and there is probably no need.
Yeah.
You know,
Okay.
the if you go and look at the types of renal cell carcinoma, you will be really there are so many different types, right?
Mm-hmm.
Most common is clear cell renal cell carcinoma, almost 80%. Then another 15% is going to be papillary and chromophobe. The other 5%
Yeah.
is a wide plethora.
Mm-hmm.
You have collecting duct, you have medullary, you have a lot of different ones, and it becomes really hard.
Yeah.
And and also the likelihood, if I see an enhancing renal mass, the likelihood of that being a renal cancer is already very high. So
Mm-hmm.
I don't need to really create another classification system for that. Whereas on the cystic lesions, it makes sense. You see cysts quite often. It's very often, very common. And then now you're looking septations and stuff like that. So that kind of helps. And also another thing that I did not bring up in my talk, there is a lot of studies which actually looked at cystic renal masses. One of the largest came from NYU, where Martin Bosniak used to work. They found
Mm-hmm.
that most cystic renal cell carcinomas, or almost all the cystic renal cell carcinomas, most of them are indolent. That means they never found even Bosniak 4, category 4 cancers. If they really categorize it, really, that means, it was truly a cystic lesion with a solid component,
Mm-hmm.
Bosniak 4. rather than a large mass which is necrotic, which is not a Bosniak 4. It should not be in Bosniak at all. Most of them, almost all of them, were indolent. That means none of them had metastases. So cystic renal cell carcinomas belong to a different category already, in aggressiveness. It is already indolent. So that is very important to understand.
Okay, thank you so much. One last question
Sure.
regarding follow-up imaging for active surveillance of these lesions. So you said when there is a solid mass, they put into two buckets, whether wait and watch, or they do they do any kind of treatment like radio or cryoablation, or microablation, or surgery. So this wait and watch, how often does your institute do a follow-up imaging on them?
More often than many other places, maybe.
Yeah, that should be true.
Yeah. This is an investigational question. This is
Okay.
done along with the American Urology Society.
Okay.
I'm not too certain how frequent, but it is at least once in 6 months, cross-sectional imaging, and there are advantages and disadvantages to this, because now you're increasing the um, resource that using radiology a lot. I'm not, I don't have it off my hand, the the um, you know the frequency of imaging. I think it is every 6 months, if I
Okay.
remember from the cases that I've seen.
Okay.
And you don't even know how long I have to keep them imaged for, right?
Exactly.
Because
Exactly.
what you're looking for is, in the slide that I showed, we know that they are all renal cell carcinomas, or maybe most of them are.
Yeah.
They don't grow that much.
Yeah.
And so too frequent is also tough, but you don't want to sit on something which might metastasize, right? So, or if it's
Yeah.
growing, then you get nervous. So it is a little bit of a wait and watch, or
Okay.
even that policy. So
Yeah. Thank you so much.
no problem. My pleasure. If you have any other
Sure,
questions, please.
yeah, I have a question for you from our attendees. Sometimes papillary carcinoma looks just like cyst, and when the lesions are too small, it is very difficult to measure the density. So,
Right.
uh, is it just safe to follow up with imaging, or we can just ignore it if it's too small?
I um I am more of a believer in kind of I mean, it depends on how confident you are that this is not enhancing, right? So a lot of the times when you look at a nephrographic or an excretory phase, and you can see it, that it is not enhancing, even if you don't measure it, I generally ignore it. I strongly believe that imaging, although is one of the greatest advances in medicine in the last decades, a few decades, is also one of the culprits for increasing costs along everywhere, right? So, if I start calling incidentalomas like small lesions like that, then it's really not going to be very useful. There is a very nice paper called the White Paper from I think it's the American College of Radiology, on all these incidentalomas, which I strongly recommend all the all the attendees to kind of download and read, which actually gives a kind of a reasonable way of what can be ignored and what should be followed. Yeah, in my own practice, if it is a small lesion that I cannot characterize, I don't even bother too much.
Okay, thank you so much.
But also, my
That'll be
practice
all.
is a little different. I work in a cancer center, and I can ignore a lot of things. But if I was out there in the general public, um, and doing general radiology, or anywhere else, I probably will go and read that white paper and follow it. So
Sure, that makes sense. Thank you, Professor Vikram. That was a wonderful talk today about renal mass, and we get a lot of highlights from you. And thank you again. And with this, we have come to the end of our session for today, and I would like to remind all our participants about our next session that is going to be next Saturday evening Asian time. And with this, I'd like to end our session for today. Thank you all.
Thank you. And if any questions, you can direct me on my email and I'll try to answer it. Thank you very much.